Prostate, Adjuvant, and Salvage. PSA nadir should occur 4 weeks after robotic radical prostatectomy, 2 to 3 years after external beam radiation, or 3 to 4 years after brachytherapy. The transient PSA bounce is a transient rise in the PSA. It's usually less than 2 nanograms per milliliter. For brachytherapy, there's a 15 to 30% incidence, and 90% occurs within the first 3 years. External beam, it's somewhat less. There's a 10% incidence, but the median time is shorter. It's around 9 months. So again, PSA bounce, transient rise in PSA, usually less than 2 nanograms per milliliter. Brachytherapy, there's a 15 to 30% incidence, 90% occur within 3 years. External beam radiation therapy, there's a 10% incidence, and the median time is 9 months. Failure after external beam radiation, per RTOG, you need 3 consecutive increases in the PSA after radiotherapy. For clinical trials, the date of failure should be the midpoint between the post-irradiation nadir PSA and the first of the 3 consecutive rises. Phoenix criteria is the new standard for what's described as biochemical failure after external beam radiation. This is your nadir PSA plus 2.0 nanograms per milliliter with or without hormonal therapy. The date of failure should be at call, not backdated. Management recommendations, adjuvant radiation indications classically were PT3 disease, meaning extracapsular extension or seminal vesicle invasion, positive margins, which predicted good outcomes with undetectable PSA. You treat as soon as 2 months have elapsed postoperatively, but wait for up to 6 months for urinary symptoms to stabilize. Salvage indications are mainly for biochemical failure after surgery. This is a PSA of greater than 0.2 nanograms per milliliter on 2 occasions, or a PSA greater than 0.4 nanograms per milliliter once. Detectable PSA after being undetectable. Additional workup, PSA DT, CT or MRI, bone scan, prostate bed biopsy if imaging suggests recurrence. Post-prostatectomy, the PSA half-life is 2 to 3 days. Post-op PSA should be in 0 to 2 weeks. The evidence for adjuvant radiation therapy, the first trial is SWOG 8794. By the way, this PSA DT is PSA doubling time. SWOG 8794/RTOG 9019, Thompson, JAMA 2006. This is 473 patients. Any PSA but had PT3 disease, again, extracapsular extension or seminal vesicle invasion, or with positive margins. Immediate adjuvant radiation, 60 to 64 gray versus observation with delayed salvage radiation, I think in around 30%. Median follow-up was 13 years. The results, adjuvant radiation to 60 to 64 gray in these PT3 positive margin or positive seminal vesicle invasion was associated with a 10-year biochemical progression-free survival increase of around 30%, so 58% versus 28%. And again, the 28% biochemical progression-free survival is associated with the observation group. There's an increase in 10 and 15-year overall survival by 10%. But this is at the cost of increased toxicity. There was a stricture in 18% with adjuvant radiation versus 9% with salvage. Rectal toxicity was 3% with adjuvant radiation versus 0% with salvage. Incontinence seen in 6% with adjuvant radiation versus 3% with salvage. Overall hazard ratio of 2. Every subset benefited. The caveats to this trial is that overall survival and distant METs benefit might be explained by the fact that the patients had worse Gleason scores in the observation arm. Also, 30% of the observation arm got radiation, so is the overall survival benefit mainly seen when radiation is compared to no radiation as opposed to just delayed salvage. The other trial is EORTC 22911. This is Bala, Lancet 2012, basically showing that adjuvant radiation improves progression-free survival, but not distant METs or overall survival. Again, SWOG 8794, Thompson, JAMA 2006, 473 patients, any PSA but PT3 disease, positive margins, positive seminal vesicle invasion, immediate adjuvant radiation, 60 to 64 gray versus observation, which is delayed salvage in 30%. Median follow-up of 13 years. Results, Adjuvant radiation improves 10-year biochemical progression-free survival by 30%, 10-year and 15-year overall survival by 10%, but at the increase of toxicity with stricture, rectal toxicity, incontinence. Next is salvage radiation. Tyndall nomogram is used for no-negative prostate radiotherapy patients. It's a nomogram to predict biochemical failure in distant mets after salvage or adjuvant radiation was generated with many patients. First trial, RTOG 9601, FANG JAMA 2020. This is looking at the role of ADT with salvage radiation. These were 761 patients after radical prostatectomy, either PT3N0 or T2N0 with positive margins. They had an elevated PSA of 0.2 to 0.4. CT, abdomen, pelvis, and bone scan were negative. PSA failure in RTOG 9601 was defined as greater than 0.5 if the PSA was 0, or 0.3 above whatever the nadir value was. They were randomized to salvage radiation, 64.8 gray alone, versus radiation with 24 months of bicalutamide, 150 milligrams, which is delivered concurrently and adjuvantly. 10-year freedom from progression was 30% with radiation alone versus 46% with the ADT. 10-year overall survival, 71% radiation alone versus 76% with ADT. 12-year distant mets, 23% versus 14%. There was no overall survival or distant met benefit if the PSA was less than 0.6 per Robert Dess. The late grade 3 and 4 GI and GU toxicity was similar, but the gynecomastia was 70% within the group that received bicalutamide versus 11% radiation alone. The bottom line from RTOG 9601 is that adding bicalutamide to radiation improves freedom from progression, overall survival, cause-specific survival, and distant mets. The next trial, JETUG AFU 16. This is looking at the role of ADT with salvage radiation. This is PT2 to T4A, prostate cancer, with a rising PSA of 0.2 to 2 after radical prostatectomy, without evidence of clinical disease. Salvage radiation was delivered 66 gray and 33 fractions alone, versus salvage radiation with goserelin times 6 months. Again, ADT here was associated with biochemical progression-free survival, 80% versus 62%, but no difference in 5-year overall survival, 95% versus 96% basically. 10-year distant mets was 31% versus 25% associated with ADT. The bottom line from JETUG AFU 16 is that adding ADT to salvage radiation improves distant mets and progression-free survival. The next trial is Radicals. This is looking at the role of adjuvant versus salvage radiation. This is 1,396 men with intermediate to high-risk prostate cancer, status post-radical prostatectomy, and a post-op PSA of less than 0.2, with one or more of the following. They either had PT3 or T4 disease, Gleason 7 to 10 disease, preoperative PSA of greater than 10, and positive margins. They were randomized to adjuvant radiation versus early salvage at PSA failure, defined as PSA greater than 0.1 nanograms per milliliter and rising times 2, or any PSA rising times 3. The radiation was 66 and 33 fractions, or 52.5 gray and 20 fractions. Whole pelvic RT to 56 gray was optional. ADT, none versus 6 months versus 24 months. The 8-year biochemical progression-free survival was not different. The distant mets outcome are pending. GU incontinence was 5.3 versus 2.7%. Urethral stricture was 8% versus 5%. Results, there's no difference in biochemical control, with worse toxicity seen in the adjuvant radiation therapy arm. The artistic meta-analysis looked at patients with positive margins, T2 to T4 disease. Note that 78% had Gleason 7. This is a prospectively planned meta-analysis of radicals raised in JETUG AFU, looking at salvage versus adjuvant radiation. Biochemical failure was a PSA of 0.4 or greater. The results, there was no difference in 5-year event-free survival, 88 to 89% with a P of 0.70. This is to be reported with overall survival, distant mets, prostate cancer-specific mortality, ADT endpoints in the future. The bottom line, there is no difference in biochemical progression-free survival between adjuvant and salvage radiation. Salvage radiation spared patients from treatment and reduces adverse effects and is thus preferred. The caveats, there were very few high-risk and very high-risk patients included in this meta-analysis, so should this really apply to them? Last is SAC 0910, Gajar, GU ASCO 21, which is looking at the dose for salvage radiation. 350 patients randomized to either 64 gray and 32 fractions or 70 gray and 35 fractions. The 6-year biochemical progression-free survival was not different. There was no difference in progression-free survival, overall survival, or time to ADT. The grade 2 GI toxicity was 7% versus 20%. The bottom line here is that salvage radiation to 70 gray leads to no benefit and has worse GI toxicity. Coport is an ongoing trial looking at the role of hypofractionation in the salvage setting. 66.6 gray and 37 fractions versus 65.25 and 25 fractions. In terms of technique, the dose is 64 per NCCN based on SAC 0910. If there's a positive nodule in the prostate bed, you boost to 72 gray. CT SIM is the same for definitive. MRI fusion or urethrogram to identify the area of the anastomosis, the vesico-urethral anastomosis. Contour via RTOG guidelines and review surgical pathology. Volume, CTV, the prostate bed is defined. The superior border is the seminal vesicles of the vas deferens or 3 centimeters above the pubis. Inferior is the top of the penile bulb or 1 centimeter below the vesico-urethral anastomosis. Above the pubic symphysis, the anterior border is 1 to 2 centimeters into the bladder. The posterior border is the mesorectal fascia. The lateral border are the sacrogenital-pubic fascia. Then once you get below the pubic symphysis, the anterior border is just posterior to the pubic symphysis. The posterior border is anterior to the rectal wall. The lateral border is the medial border of the levator ani muscles, and you include the retained seminal vesicles if involved. The PTV is a 1 centimeter expansion on this with 6 millimeters posteriorly to limit extension into the rectum. You can consider including pelvic lymph nodes per the SPORT trial. SPORT, which is Pollock Astro 18, looking at is there a benefit to ADT and whole pelvic radiation with prostate bed only RT. 3 arms, PBT is prostate bed therapy or prostate bed treatment. PBT plus 4 to 6 months of ADT and PBT plus ADT plus whole pelvic RT. 5-year freedom from progression rates for prostate bed radiation only is 71%. For prostate bed radiation with 4 to 6 months of ADT is 83%, and then the best prostate bed plus ADT plus whole pelvic radiation is 89%. So from going from prostate bed only to prostate bed with ADT, you bump up by 12%, and then from adding whole pelvic radiation, you go up by 6%. So there's improved freedom from progression with whole pelvic radiation and ADT. The 8-year distant MET rates were significantly improved between arms 3, so all of these therapies versus just the radiation to the prostate bed alone, but there's no difference between arms 2 and arms 3. We're still awaiting toxicity data from this. The bottom line is that prostate bed only radiation with ADT and whole pelvic radiation leads to an incremental improvement in freedom from progression at 5 years. Caveat, most benefit is only in the PSA greater than 0.34 on analysis. The study was also done prior to PET and MR imaging. There's no toxicity results, and the only distant METs benefit are really between arm 1 and arm 3. In terms of setup, you want daily cone beam CT. Dose constraints, bladder minus the CTV, V65 less than 50%, V40 less than 70%. Rectum, V65 less than 35%, V40 less than 55%. Again, bladder minus CTV, V65 less than 50%, V40 less than 70%. Rectum, V65 less than 35%, V40 less than 55%. In terms of toxicity, follow-up, and outcomes data, earlier salvage is better when the PSA is less than 1 and is associated with prostate cancer-specific mortality benefit in a retrospective review. Outcomes: biochemical progression-free survival at 4 years for a PSA of greater than 2 is 20%. Biochemical disease-free survival at 4 years with a PSA of less than 2 is 50%. Adjuvant or salvage radiation is associated with a higher risk of impotence, incontinence, and stricture. The grade 1 to 2 GI and GU toxicity is 20%, again, with adjuvant versus 5% with salvage, and urethral stricture is about 18% with adjuvant versus 9% with salvage. Toxicity of salvage radiation from Hayes, JCO 2005. GI, 5% need lasers, 10 to 20% have mild spotting in the rectum. Less than 1% increased risk for all the other toxicities over radical prostatectomy alone. 30% increase in erectile dysfunction versus radiation alone, so about 60%. Again, these are the volumes. When you are above the pubic symphysis, the anterior border would be going 1 to 2 centimeters into the bladder. Posterior would be the mesorectal fascia. Laterally are the sacro-genitopubic fascia. Once you get below the pubic symphysis, the anterior border is just posterior to the pubic symphysis. The lateral border is the medial border of the levator ani. Posterior is the anterior border of the rectal wall, and you extend this back a little bit. You include the retained seminal vesicles if they were involved.